This is 99% chance.
Okay.
My body will.
Like if you wear like a certain
Yeah, because they can't go up there and get like if I make it to like 100 years old, I'm just gonna like hike Everest just so I can die.
Just so I can die up there. Okay. Okay. For sure. I want to be donated, so then, you know, you don't have to worry about a funeral. You just have a little memorial service. Just have a party. That's all. Some good food. Let some balloons go, whatever you want to do. And then I'll be donated to a place like the U or something.
They put you in a pod and you become a tree leader. Like, that's what I want to do.
All right, who's on blue button? Did anybody get on there? Mark, did you say you were going to get on blue button? I just wondered if they can see what I see.
Oh man, I think I did that little
Okay.
Yeah, we're good.
Okay. And can you see the screen okay?
Good enough. The power.
Yeah. Okay. All right. So first, one quick announcement. The Q&A that I usually do on a Friday, I go to primaries this week with my group. And so we'll do it Thursday in between some student visits. So like at 9:30. So 9:30 Thursday is the Q&A. If you feel like you want to show up so I don't have to talk to myself, that'd be really nice. And then, but I'll record it for you if you can't. All right, today's joke is actually a rap. So I'm going to rap for you.
Oh, wow.
I'm gonna get on my bling here. Get on my hat. I know it.
You're gonna put it sideways?
I am.
You need Megan to tattoo yesterday as well? Or?
I should have, huh?
Yeah. You need to clean on your teeth.
Yeah, I get a grill.
Put your gun on your teeth. Make it cold.
Okay, so this is called the veggie wrap. Only there's more than just veggies in it. There's fruits and veggies and milk and meat. There's all kinds of fun things. Don't give me no grief. Here's the beef. Let us get down with the broccoli crowns. Pass me some cheese, if you please, for my potato, tomato. Eating right is my motto. Banana, fofana, feet, fofana, eat a banana. If you care at all for your body, you'll treat it just right. And then you'll look peachy. You'll be out of sight. Celery and spinach are veggies so green. Stick with those and you'll look good in your jeans. I know all this food is making you drool, so eat an apple a day. And don't be a tool. There's nothing like turkey to make you feel perky, and peppers and onions go good with beef jerky. Always take your Beano, don't be a fool, so when you eat that burrito, you'll still be cool. Milk is good for your teeth and your bones. Just go easy on the ice cream cones. Speaking of treats, Fat Boys and Creamies are really good treats, but you can only eat them after you beat. So to end this rap, all I gotta say is if you eat good food and drink water that's clean, your body will be a lean, mean machine. Word.
You remember all of that?
I've done it for a long time. We were sitting one night. I can't remember.
Oh my gosh, we better be recording.
Yes, I don't know that they can see me very good, but we were recording. Who said that?
Maddie.
Oh, Maddie. Thanks, Maddie. I really appreciate the reinforcement. All right. What's that? Oh, I thought you said something that I needed to know. Okay. All right, Peds GI, super fast, down and dirty, like 45 minutes. And then you can move on to all the liver stuff with Vicki. Okay, so we have gastroenteritis, diarrhea, clinical manifestations, nausea, vomiting, diarrhea. That's not a hard one. They can have a sunken fontanelle. So what do you like?
You said diarrhea, that's not a hard one.
I know. Very true. Very true. Sunken fontanelle, where do you check? How do you check their fontanelle?
While they're sitting up.
While they're sitting up, yeah. They can have really sunken eyes, lethargy, irritability, decreased urine output, and decreased PO intake. They can complain of a lot of pain, and I think on the one that I posted, it says no tears.
No tears, yeah.
I have an older version that's up here than what was saved and sent to you because I realized that I didn't have it on there. Sometimes when they're really dehydrated, they'll cry and cry and cry and have no tears.
Oh.
So that's a good sign that they don't have enough fluid on board. All right, so causes can be intestinal infections like E. coli, salmonella, C. diff, and then a lot of viruses like rotavirus. The new rotavirus vaccine, well, it's not super new, but it can prevent approximately 80% of cases. So you remember when we did our vaccine video, Vaccine Wars or whatever, when we had Peds GI, and they were talking about different vaccines, and the lady that was the college-educated lady that had so much to say said that rotavirus, that it doesn't prevent deaths in this country because people don't die from dehydration in this country. Wrong. That's wrong. Not a lot compared to third world countries where they do send this vaccine to help to a lot of third world countries, but it does prevent a lot of hospitalizations because these babies will get like tenting. I don't know if you remember seeing on one of the videos the tenting, and they can be really dry and have a lot of trouble. Diarrhea, emotional stress. So if their parents just went through a divorce, yeah.
Vaccine, is that part of the regular vaccine?
Yeah, it's given twice or 3 times, depending on the manufacturer, 2 months and 4 months. One of the manufacturers has to go 1 more dose, so I think they do 6 months. But both of them do 2 and 4. Okay. Emotional stress, so if parents went through a divorce recently, can cause a lot of stomach aches and diarrhea, a move or a change in schools. And school is one thing where if kids have a little bit of anxiety with school, and then they get there and they have kind of a belly ache and they send them to the nurse and the nurse sends them home, it almost reinforces. They're like, oh, belly ache, oh, you know this.
That for a whole year.
Yeah.
You threw up every single morning.
Mm-hmm. Yeah. And you do all kinds of tests and they don't know, they can't find anything. Yes. So it can be anxiety. New siblings, so if there's a birth of a new baby, and then if there's a death in the family, that a lot of these can cause diarrhea and vomiting. Food intolerance and allergies like milk or gluten or any new foods. Medications, antibiotics. Antibiotics should most of the time be taken with some food. Your mycins, like erythromycin, that one can cause a lot of stomach upset and a lot of diarrhea. Colon disease, but on that note, with erythromycin, we'll talk about a disorder coming up that actually needs erythromycin to help with that motility. So in a low dose, then it kind of helps move things along. So it kind of works both ways, I guess. Colon disease, like colitis, necrotizing enterocolitis is often a newborn, particularly a preemie. Disorder, and they have a necrotizing part of their bowel, and they usually have to have that piece of bowel cut out. They have a colostomy for a little while so that they can rest that bowel, and then they'll reanastomose the ends together when they take down the colostomy. And then they have what they call short gut, because we've taken out a piece of their gut, moved it together, and now they've got shorter guts, basically, so they call them short gut kids. And they have chronic nutrition issues because they have a lot of diarrhea. Surgical procedures like a colostomy, an ileostomy, or the short gut resection. So obtain the following. History. I don't know, I almost changed it a different color because this is so important. Pieces of the history are all here, but you don't want to just get pain or just get bowel patterns or just get food intake. This is all history. Okay, so you really want to make sure that you've got that all. You want to ask regular bowel patterns. How often do they go? If they go twice a day, every day, and now they're going 4 times a day, every day, not as big a deal as if they go once every 3 days, and now we're going 4 times a day. Does that make sense? It's very different for their body, different pattern. If there was a recent illness or travel, they can bring back, like parents that might have a little bit of what they call traveler's diarrhea or something like that, can bring back Shigella, which is can kill an infant, and it causes profound diarrhea. And that's one thing that you ask the color, consistency, everything like that about the stools. And if they say they're white or clay-like, that's often a parasite. Caldera, so you want to make sure that you've got all the ins and outs. Sometimes the things that you say just go so many different ways of their pain. The description of the stool, the color, odor, consistency, any food intake, especially new foods, and then other signs and symptoms of illness, like if they have a fever, if they're vomiting also. Get a baseline set of vital signs and their weight. And then look for signs of dehydration, increased thirst, dry mucous membranes. Sometimes we don't really pay attention to that. They can have dry, cracked lips, no saliva, no tears, their little eyes are just dry. Tenting, so when you guys know how to do that when you check your skin turgor, and then you will have tenting. Sunken eyes and a sunken fontanelle. And then a rapid thready pulse, but I actually changed it to weak because it isn't always thready. Thready is where it's weak, but if you push a little harder, it obliterates the pulse. If you have that, you're in a lot of trouble. That's not just simple dehydration. Okay, that is more profound, and we'll talk a little bit down here about the extra fluid loss. They'll be very lethargic, have decreased urinary output. And so asking parents as part of the history how often they've changed diapers and how wet they are. If they say, well, I've changed them twice, but they weren't very wet, that's a good indication that we don't have enough fluid on board. Fluid loss of greater than 10% indicates a more severe dehydration. So if you just remember that when they have greater than 10%, you are going to see some of these things where you won't just for general dehydration. You'll see hypotension. They can be cool and mottled in their extremities, and capillary refill time might be greater than 3. They're very hypotensive, and so we're not perfusing very well. Observe their stools for color, consistency, amount, and odor. And then for tests, they can test for occult blood, where they look and see if there's any blood in the stool. And they can do stool cultures so that they can figure out if it's a virus, bacteria, parasite, whatever. Sometimes they'll send parents home with a little stool collection kit, and they have to collect their own and then bring it back to the hospital. And then strict I's and O's. Not just output, not just intake, the relationship. Okay, so make sure that you've got both. It makes me a little crazy how often nurses do not keep I's and O's anymore. Like I will get concept maps all the time where they're like, we weren't checking this, or they'll say they're on a 2,000 mil restriction, fluid restriction, and then they'll have no I's and O's. Well, we didn't calculate I's and O's. Seriously? They're on fluid restriction. How are you going to know? Right? And if we're restricting their fluids, we need to make sure that they're not having more out than what we're putting in, or they're going to get too dry. So you need to have that relationship. Reduce the risk of transmission. Put them in isolation and do really good hand washing. Make sure that families know that diarrhea, vomiting, those kinds of viruses and stuff are very contagious. Maintain adequate hydration and nutrition, so IV or PO. But here's the key. They have to be able to PO before discharge, right? We can't just give them a bunch of IV fluids and send them home, because where might they end up? Right back with us. And so if they're on IV fluids and you start PO and they have a massive amount of diarrhea or they start throwing up, what do? Stop feeding them. Right? You got to go back to resting that belly. Okay, belly's not ready, so we go back to IV fluid. Okay, and then stool replacement with IV fluid. So sometimes they'll be running an IV of like D5 half and S with 20 of potassium. Gives them some sugar, some salt, and some potassium. So it's a nice fluid for pediatrics. And while that's running, they'll put in a second IV with just NS. And the NS only runs per stool replacement. So if you change their diaper, they have 30 mils out. They program this for 30 mils, and they run in 30 mils of NS to replace what came out in the stool, despite what the other one's running. It might be running at 25 all the time for the whole time they're here. A brat diet. So I'm looking, and you guys might not be old enough to know what this is, but it's bananas, rice, applesauce, and toast. And they used to say, and they still do, it's just they think that you need to add a few other things. That's why it's controversial. So those bananas, rice, applesauce, and toast are very mild. They don't cause GI upset. They also don't cause constipation or diarrhea. They're just kind of there. They just kind of fill their belly. But they say that they need more salt, and they need more sugar, and they need some protein. So a simple protein, like a couple little pieces of a chicken breast, even if it comes in the form of a chicken nugget, I guess it gives them a little bit of protein. But it also gives them a lot of salt, right? It gives them a lot of sodium if you do it that way. A little bit of sugar, so giving them Gatorade or Pedialyte is really good to do with their brat diet. And then some probiotics. Probiotics will help replace that gut normal flora. But you have to be careful and watch for pediatric doses, because sometimes parents think, oh, a little's good, so a lot is better. And that's not the case. So make sure that they stick with pediatric doses. And they do have some chewable ones that don't taste terrible. So that's pretty good. Promote skin integrity, clean the diaper area, and soothing and protective ointment. So here's the thing that I would teach parents with that. You don't want to wipe off, so you want to clean them off really good, dry, and then put Desitin or something on, just slather it on there. The zinc oxide in there will just stick right to their skin and create a barrier. Then when they go to wipe off any other stool, don't wipe off all of the Desitin. Just wipe the stool off the Desitin and replace little spots that it may have come off. Does that make sense? Otherwise, if you keep scrubbing that off every time, pretty soon skin is going to start coming with it. And it'll get really, really sore. Also, with the protective ointment, if you mix Mylanta and Desitin, stir it up in a paste. You know this, huh?
Yeah, add nystatin and you're caught.
Yeah, and you can add nystatin, yep. So the Mylanta and the Desitin, I had a pediatrician tell me this when my son had rotavirus, and he said that Mylanta kills the acid in it, and the Desitin makes it stick. So it's a little bit hard to make it mix in a paste. And if they end up, and the nystatin can help them not get any other infection, like a yeast infection or anything like that. Because when you lose all that good bacteria in your gut, it sets them up for a yeast infection. And then administer probiotics. I just have it starred just to make sure that you remind them pediatric doses. And then monitor their vital signs really well. So here's just some of the protective ointments. My favorite is Desitin, but the others do work well too. Just know that sometimes wipes with fragrance in them are going to start to burn. And so just a washcloth, or like a little disposable washcloth with just a little bit of water, a little bit of soap might even start to burn. So you don't want to use just something dry, because it won't get it all off there. And you might end up starting to pull some of the Desitin off. But you just a little, they have disposable cloths, I guess, that are dry. You could even use a gauze or a dry washcloth or something. Just get it down. And don't put soap on it or anything like that. If they have unfragranced wipes, then those will be okay too. But the fragrance will start to burn. Emotional needs, so the causes of the GI upset, we need to kind of get to the bottom of this. Importance of GI rest, NPO. So we need to rest that belly. If they're vomiting or having a lot of diarrhea, we need to just stop feeding them. Okay, and then rest that belly, and then start to feed them a little bit at a time back while we're running IV fluid. ADAT is advanced diet as tolerated. So give them a small amount. Start with clears. That works really well. It's gentle on their stomach. And you can start to move right into kind of that brat diet with some replacement of electrolytes. and see how they do. Do not use medication unless ordered by their healthcare provider. So things like Imodium, because you want to get that virus, bacteria, you just want to move it all through. Okay. Now, if they were having diarrhea chronically for a long time and they kept ending up back in the hospital and nothing was coming up in stool cultures and they're thinking it's more emotional distress, then they may go ahead and give them a small dose of Imodium now and then. But for the most part, for the acute illness, they won't. And then really good hand washing. Okay, with motility disorders, we're going to talk about chronic constipation, Hirschsprung's disease, intussusception, gastroparesis, and imperforate anus. These are like two slides. It's the down and dirty of it. Oh my gosh. So it's very, very, they're very different. And so I think they're pretty easy to distinguish from each other. So chronic constipation causes they don't have enough fluid or they have too much soda, right? And we don't have a lot of water, juice, milk, that kind of thing. Now, if they have too much dairy, it constipates them, like cheese. If they sit down and they tortillas and cheese, like nachos or a quesadilla with a glass of milk, and then they just sit there. Where's the fiber and exercise? Yeah, decreased exercise. How many kids nowadays just want to sit? They want to play. They want to be on their screen. And so if they're having a lot of dairy, not a lot of fluids, not a lot of exercise, they don't like salad or veggies, we're kind of setting them up for a problem here. Ignoring their body signal. If they're outside playing, how often do they want to come in and go to the bathroom? No, they just want to hold it. Just want to hold it. I had a pediatrician tell me, if your kiddo comes in to go to the bathroom, don't make them be done playing at that point. Like even if you were about to call them in, let them go back out for like 10 minutes or 15 minutes so they don't associate coming in to go to the bathroom with having to be done playing. So I thought that was a really pretty great piece of advice. Toilet training pressures. And so they feel like they want to please everybody, but maybe they keep having an accident. And so then they're feeling really bad and feeling really pressured to be potty trained. And then avoiding public restrooms. I think my sister's horrible with this. Her little boy was so constipated all the time because every time they were out and about, he needed to go to the bathroom and she'd be like, no, it's really gross. It's really dirty. Just wait till we get home. And then when they get home, you don't really need to go anymore. And so then the next time you needed to go, it almost seemed like they were just out doing something else. And she's like, wait till we get home. So she had to just kind of grin and bear it and let him go to the bathroom in a public restroom. You do the best you can, right? You bring, then you have your diagnosis, so you can do an x-ray. And a barium enema will help see better in the x-ray. So they'll do that enema. It has contrast in it, and they'll be able to see the motility. So if you have a blockage, then the enema will only go up so far. Sometimes they'll have them drink barium and see how far it goes down and see the motility that direction. And then it lights up on the x-ray a little bit better. Treatment, so do diet changes. Good luck with toddlers with that. That's a little bit hard to do. And so make sure that they have any vegetables that they'll eat. Like I had boys that ate raw broccoli and boys that like cooked broccoli. So if I was having broccoli for dinner, I served it raw with ranch and cooked with a little salt and pepper or something, you know, so that everybody would eat broccoli. But I usually would make 2 or 3 or 4 vegetables and just say, pick 2. I don't care what 2, just pick them. And one might pick corn and broccoli, and one might have a salad and carrots, or you know, whatever. And they just learned to eat the vegetables that they liked instead of saying, I won't eat vegetables. Medication, so stool softeners, laxatives, enemas, and suppositories. These here, the enemas and suppositories, can start to cause a lot of nervousness and anxiety because those aren't super comfortable, right? And then the laxatives sometimes will cause cramping and abdominal pain. And so then they start to have more anxiety around having a bowel movement. Stool softeners are a little more gentle. And with Colace, you can actually prick it and drip it on something so that if they can't swallow a pill, And you can actually do that, and you can just drip it on something that they're going to eat. They'll be able to have the choice. And then a bowel clean out. Sometimes they have to hit them from the top, hit them from the bottom, and get it all cleaned out in there. All right, Hirschsprung's is persistent constipation. It has the absence of parasympathetic ganglionic cells. So there's no peristalsis in the affected region. So you might have, it's going along just fine. Most of the bowel is not affected. And then you have this small piece down here, the rectosigmoid colon, and that's where it's most common. Because there's no peristalsis there, because the lack of ganglion cells, then you start to back up here and get what they call a megacolon. And it just backs up right in there. Sometimes it can affect the sigmoid colon or the entire colon, and very rarely into the small bowel. But most of the time, by far and away, this is where I've seen it, rectosigmoid colon. And they will end up having to remove that piece of colon. So directly above the affected area is greatly dilated. So, I have a video in a second, I'll show you. Clinical manifestations with a newborn, there's no stool in the first 24 to 48 hours. So they need to be checking that out. They can have abdominal distension, bilious emesis, so they're throwing up bile, and then a lot of gas and abdominal pain. Diagnosis with the history, so if they haven't had any stool in the first 24 to 48 hours, they shouldn't be sending them home. Every once in a while, these kids get sent home, and they'll end up right back with these other symptoms. So asking them a little bit of history. Get an x-ray using contrast dye or do a rectal biopsy. So they can go in and just collect a little piece of the cells, scrape some of the cells from the colon. With treatment, they need to do a surgery. They place a colostomy and they cut out the piece of affected bowel. And then when they do the reconstruction, they can do a takedown where they internalize this. So once that bowel has healed from surgery, then they'll go in and they'll what they call anastomose. They'll anastomose the ends together and then let it heal while you just give them kind of clears. And sometimes they'll do it. They'll keep them in the hospital for a couple of days and we'll just run IV fluid or sometimes even TPN for a couple of days while that bowel starts to heal. Okay. Hirschsprung's can be. It can be genetic, but often there is nothing else linked. It's kind of idiopathic. It just happens. Yeah. Okay, we're going to go for a video here and hope for the best, right? Because it's a pretty cool video, I think. All right, are you seeing on your screen what I'm seeing there? Oh, sorted.
A man from China just had to get almost 30 pounds of feces removed from his body. There was so much poop in this man's colon that it made him difficult for him to breathe. I know what you're thinking. How is this even possible? I'll break it down for you here on IO. Welcome back to Inform Overload. I'm Charlotte Jobre. So you see that big pink bag thing that the doctor's holding? It kind of looks like Patrick from SpongeBob, like a dead Patrick. That's a colon. That is his colon. It belonged to 22-year-old Zhu Hai, and it weighs 28.6 pounds. Hai went to a hospital because he had abdominal pain. His abdominal pain was so bad that it wasn't allowing him to breathe properly, and his belly was so swollen that he looked like he was heavily pregnant. A CT scan showed that his colon had basically become so swollen with feces that it, quote, looked like it could have exploded at any time. Yikes. This is due to a condition called Hirschsprung's disease. It's a disease that affects the large intestines and it makes it hard to have bowel movements. It occurs when the nerves of the intestine don't work properly from birth, which makes it difficult to push waste through the intestines. Hirschsprung's disease is usually treated with surgery early in life, but if it's not treated, the result is a pileup of feces and eventually a megacolon, which is exactly what happened to Zhu Hai. He left the condition untreated for most of his life. I'm not sure how he did. The symptoms can be brutal. They include constipation, diarrhea, a swollen belly, and vomiting. Zuhai had been suffering from constipation his whole life. He'd become used to using laxatives to help him go to the bathroom. But even so, there was still a huge pileup of feces, which is really dangerous because feces are made up of poison and toxins. It's definitely not good to keep that stuff in your body. So he had to go through surgery to remove the part of the colon that was swollen. A 3-hour operation later, and the enlarged colon was removed. So what did we learn from this? If you've been constipated your whole life, maybe there's something wrong. You definitely shouldn't need laxatives to help you go to the bathroom on a regular basis. The more you know.
Yeah,
The more you know.
All right, that's enough food talk for one day. Some comments from previous videos. That's what DJ said. I love the more you know joke.
Okay.
what?
All right. Okay. Did it go back?
Yes.
Oh, that's success. Okay. All right. Intussusception is where there's a telescoping of portion of the bowel and food and fluids are blocked. So it's an emergency. The blood supply is affected. So you can see here how well, I don't know if you can see well, but it telescopes on itself. So kind of how you have like your umbrella or telescope and all the pieces slide together and a piece of the bowel slides in the piece of the other part of the bowel. It occurs between about 4 and 10 months, but it can occur often like after a virus, if they've had gastroenteritis or something like that, and they've been having nausea and vomiting. Sometimes the lymph tissue that surrounds the bowel gets very swollen, and it can cause it to be kind of slipperier, I guess, and so it makes it kind of slide together. So it can have the hyperperistalsis or unusual mobility of the cecum and ileum. That's where it happens most of the time. Recent attack of gastroenteritis and the swelling of the lymph tissue. The current jelly stool, so once that comes together and you cut off blood supply, then it can start to bleed like in the tissue because we've cut off the vessels here that are feeding this piece of the bowel. And so sometimes you will have it bleed into the tissue. And with the mucus in the stools and the blood together makes kind of the current jelly consistency. So I apologize if you want current jelly. You'll never look at it the same. Clinical manifestations, they cry a lot and they drop their legs. It's very episodic, and it's not episodic because it resolves, because it will slide in and telescope and then not. So you can see here how it has kind of slid in itself there and how they're going to pull it out here. It's very painful, and the only reason that you have different episodes is because peristalsis isn't currently happening in that piece. And once peristalsis starts in that portion of the bowel that has telescoped and you're moving and having that wave-like motion through there, then they will end up having more pain. And then once peristalsis stops, then it seems like it resolves. So if a baby seems colicky after they've eaten or something, then that's definitely something that they need to check out and make sure there isn't another bowel issue. The current jelly stools, bilious emesis, and abdominal swelling. Diagnosis, you can palpate, you can actually feel a lump in their belly, and a barium enema can show that also. Treatment, IV fluid, they need to be NPO so that we're not causing a lot of peristalsis in that bowel. And then for surgery, they need to do a manual reduction. So they will resect that piece and have a colostomy for a short period of time. It isn't something that will have to stay permanent. Okay, gastroparesis. So see, they're very different, and you don't need to know like a million things about them. Okay, just the clinical manifestations and the nursing care for the different disorders. Delayed gastric emptying. So there's a mechanical obstruction. The pyloric sphincter can cause the mechanical obstruction. So here's all of your reasons to have gastroparesis. We will talk a little bit about pyloric stenosis in a minute, but they can do Botox injections. So they'll go down for like an upper GI, and they'll go down and then they'll pull out like a little rod, basically with a needle on the end, and inject Botox right into the pyloric sphincter and cause it to relax. So that can help. It's not permanent, and the first dose lasts about 6 months or so, progressively gets shorter and shorter with time. So if that's the mechanical obstruction, they do need to have a pyloromyotomy and be able to get rid of, be able to cut back that sphincter. Biochemical disorders like diabetes. Diabetes, if it has uncontrolled blood sugars, can damage the vagus nerve. And if you damage the vagus nerve that innervates the stomach, then they can have gastroparesis. Gastric infections like H. pylori, gastritis. So if they have ulcers caused by H. pylori, sometimes that can damage the lining and cause decreased gastric emptying. Medication side effects like chemo and autoimmune medications, and significant inflammation from celiacs or IBS. IBS is a really broad term. There's a lot of things that fall under that, but those inflammation from those can cause gastroparesis. So,
do little kids get H. pylori very often?
Little kids?
Or like, I don't know, pediatrics, is that a common thing in pediatrics?
I don't think I've seen it younger than teens, but I don't know that means that it doesn't happen. Yeah, I'm not sure on that. I know that like younger teens is about the youngest that I've seen it. Clinical manifestations, early satiety, so they're full really quick. Abdominal bloating and or pain, nausea and vomiting. They'll have a lot of indigestion because things aren't moving through. It's just sitting there in their stomach. And then feeding difficulties with an infant. Treatment, doing nutritional management, so you're going to have to space out small meals that they can't eat like we do, like 3 times a day or 4 times a day, smaller meals. They need to have really small meals stretched out through the day. They might have an NG or NJ. The NG was usually liquid feeding, right? And so so it's a little easier to digest. But most often you will see them with an NJ. And that just goes through the stomach into the jejunum. And then we bypass the stomach and they're just feeding the small bowel. And then they can have medications like erythromycin. Erythromycin will cause increased peristalsis from stomach down through intestines. And so it can kind of help move things through. You just don't take it in as high a dose as you would if you were taking it for an infection. All right, imperforate anus is an anal rectal malformation. It's a congenital defect where an anal opening is missing or blocked. Sometimes there are fistulas, and those are little like channels that go off. So you have this blockage, and then they have like little tunnels, and it can tunnel out to the scrotum, out to the vagina, out to the, well, usually it's the scrotum and the vagina. So if their scrotum is very swollen and they have this imperforate anus, they need to make sure that stool isn't emptying into the scrotum. And for a little girl, it can be coming out of the vagina. So when they make this anal rectal pouch and they make the opening, they need to clean out and close all those fistulas. So diagnosis, they'll do an x-ray and an abdominal ultrasound. And then for surgical repair, they make an anal rectal pouch and an anal opening. So they do a temporary colostomy, about 3 to 6 months, which is often the case for most of these disorders. And then they pull down, they make an opening for the anus, and then they pull down and make a rectal pouch. And then they let it rest and heal while they have the colostomy. And then once it's healed, then they will do a takedown and they'll re-internalize the colostomy and get all their plumbing to work. They usually will have to be on some stool softeners or laxatives for a little bit of time just to keep things soft and moving. Okay, pyloric stenosis. Am I doing okay? I think he's going to kill me if I go over because liver takes a while. The pylorus muscle thickens and becomes abnormally large. You can see it right here at the base of the stomach. Generally at 2 to 8 weeks of age, they'll start with occasional vomiting, and then you'll see this wave-like motion of the abdomen shortly after feeding and just before vomiting occurs. So I will show you this little video of this wave-like motion. So if you watch their belly from left to right, you'll see it kind of do this. And that's pretty indicative of pyloric stenosis. We're going to hope that it works again, just like the other one. Okay. So watch from left to right. You see that? How it kind of moves across there. So it will go left to right all the time. Is that kind of crazy?
No, it's like them aliens.
It's got a little alien in there. What's that?
It reminds me of the movie The Mummy when those bugs go under their skin and you can like see them crawling.
Oh my gosh, I don't know. Have not seen it. Okay. Okay. It progresses to projectile vomiting. It can be expelled up to 3 feet, but it's not limited to 3 feet. I've seen it go a long ways. Possible dehydration, because they're vomiting everything that goes down, right? We've blocked the bottom of the stomach, and so it just sits there, and then it just comes back up. They're hungry between episodes. Remember that. These babies aren't sick. Okay? They don't have a bellyache that is where they've had nausea, vomiting, diarrhea. The vomiting is because there's a stricture at the bottom of the stomach, not because they have a fever and they're lethargic and they're not feeling well. So they puke and then they look at you like, all right, who's going to feed me? Okay, who's next? I want a bottle. And they can be losing weight because we're not being able to keep down formula. So surgical correction is a pyloromyotomy. And so you can see the pylorus muscle right here, and then they just cut it back. So they can monitor, for your nursing care, monitor their fluid and electrolytes, monitor their weight, and then educate the family on what's happening, why they're vomiting, what about the surgery, what's going to happen, and then about post-op care. And then when you're doing your post-op care, it is your basic post-op care. We want to make sure that they can hold some food down. We want to make sure that that they're not still vomiting, right? If they were still vomiting, did you have a successful surgery? No. No. If a lot of times they will teach parents beforehand, before the surgery, to burp them often, like little bits, burp them, little bits, burp them. If they are having to still do that post-op, did you have a successful surgery? No, it shouldn't have to be doing that. Now, just, they drink a couple ounces, they usually need to be burped anyway, but not like the tiny amounts that they were having to do before. All right, appendicitis, last one. Inflammation of the appendix, that's the small sac at the end of the cecum. It's rarely less than 2 years because it's caused by fecalus. Anybody know what that is? Fecal.
Poop stone?
Poop stones. That's exactly what it is. And you're like, is it really that easy? It is. It is that easy. Rarely less than 2 years old because they don't have enough time really to build up all these fecaliths and have them get down in there and cause necrosis. So the obstruction causes interrupted circulation and then necrosis and infection. So they will have a fever, sometimes really high and sometimes not. So I'm not going to give you it's always more than 100.4 or it's never up to 102. Just know that it really is pretty variable. Some kids will run a slight fever and some kids will run quite a bit higher. Periumbilical pain, and then it radiates down to that right lower quadrant with rebound tenderness. So you can push, it might hurt them a little bit, you let up quick, and they're gonna hurt. Another way of testing rebound tenderness, if they're laying in bed, is to kind of bump the bottom of that right foot. And that rebound, that you kind of shake them a little bit, can do the same thing. If they flinch or it causes more pain, causes them to double up a little bit, that's really indicative of appendicitis too. And then guarding like this, they've got a hold of it. Sometimes they're pushing on it because it hurts if they let go. So they'll be pushing on their stomach. Side lying with knees flexed is the most comfortable position. Yeah.
Why does it hurt more on the rebound rather than?
I don't know the why. I wish I did. Yeah, I don't know if it's inflammation or if I really don't know. I just know that that is super indicative of it, and then bumping the bottom of their foot. Yeah. You keep asking me the why. I hate that. No, I love knowing the why. I ask why all the time. I think that keeps you critically thinking if you're always asking why. And so that is something that I've looked into, and I've never found why that is. So the side lying with their knees flexed up is the most comfortable. So don't, if you have to start an IV or something, don't roll them over, sit them up. You know, here, I need your arm out over here. If their knees are flexed and they're on their side, can you still get an IV? Yes. You can still get it in their hand, AC, wherever. Nausea, vomiting, diarrhea, sometimes for several days, sometimes for just a few hours. Pallor, they'll be very pale. Sometimes they're sweaty and chilled, and they'll, I won't say always have an elevated white blood cell count, because I have seen a couple, 2, maybe 3, where they almost missed the diagnosis because the white blood cell count wasn't elevated, out of range. So they were thinking that maybe it just had come on so fast that it didn't have time yet to respond. But other than about, I think there's 2 that I can think of, everyone else had an elevated white blood cell count. So the only treatment option is surgery. Get that little sucker out of there. And then your nursing cares, pain management. If you keep their pain under control, they will do all kinds of things for you. They'll sit up and they'll walk and they'll drink and they'll do everything you need them to do. Breathe deep, to be ready to go home, because they'll feel so much better. Post-operative care, get a good set of vital signs early on. That way, if there's a change, if there's any bleeding, and they're changing to have an increased pulse, so they're hypotensive, you'll be able to assess that really quickly. Look at their wound, their dressing, see if they have a drain. Do you remember in our Peds sim, and that little one had a drain coming out of the incision? You can't tell me you don't remember that. It was one of my favorite moulage drops. They will often have just lap sites, but occasionally they'll have a drain if it was a rupture. Okay, so if it was a ruptured epi. Check for bowel sounds. Please, 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 before you feed them. Like I always see, well, not always, but I often see in concept maps and things like that, that they had hypoactive bowel sounds and a regular diet that they're eating 100% of them. Wow. Don't feed them a regular diet if they have hypoactive bowel sounds. Okay? Feed them clears, maybe advance it a little bit, but don't give them 100% of a regular diet until they have better bowel sounds, because you can end up with an ileus. Things are just slow. Your guts are slow to wake up. They're ornery, and the more you touch them and manipulate them, the sleepier they get. So definitely nothing if there's no bowel sounds. Nothing's going to move. So you don't want to be feeding them. And then advance the diet as tolerated per your bowel sounds, per their nausea and vomiting, how they feel. Monitor for infection, like peritonitis. Sometimes they will get a localized abscess. Most of these are at risk if there's a rupture. And then administer antibiotics pre and post-op. It used to be that everybody that went in to get an appendectomy would have a dose of Ansef, like a gram of Ansef. And then coming out, they might have 2 more. Well, then as they reevaluated all the administration of antibiotics, they're like, well, really, if it hasn't ruptured, why are we just giving antibiotics? We don't do that for every surgery. And so they stopped giving them, usually if there is a question of rupture, or if they know that they've ruptured, then they will do antibiotics. All right, promoting mobility after surgery, get them up and moving as soon as possible. That'll help get their bowels moving. That'll help wake everything up. They're usually pretty afraid that they're going to pull stitches or little steri strips, and then the fear of having pain. So if you want them to sit up in bed and they've had abdominal surgery, how is this? How fun is that to sit up in bed? You're like, here, use your abdomen that we just cut into, right? And sit up in bed. And so have them roll on their side and grab their rail and push themselves up sideways. And now they're sitting at the side of the bed and they haven't had to use their abdominal muscles. So that's helpful. That's a helpful way to get them up. Encourage parents to encourage kids, because sometimes parents have been afraid because they got sick so quick and now they've had surgery and it's a previously healthy child. And so they're not used to being in the hospital. And so they get really nervous and the kids kind of feed off that. And then open appy considerations would be a little different if they had to have an incision. Then you're obviously not going to get them up and moving quite as fast. But sooner rather than later, and get them at least sitting up and blowing bubbles. That's kind of their version of incentive spirometry, right? Okay. That's Peds GI. I know. I think I have like 11 questions on this test that are Peds. There are not. Oh yeah. Did you motion her to come in?
Good.